Thank you, everybody, for joining me this morning, morning in Toronto anyway. So good morning to those who are joining from here and good afternoon to those who are joining from Europe. So the topic of my presentation today is peripheral electrical stimulation. I'm going to go in depth regarding the technique of application, and then we'll briefly touch a little bit on its role in neuromodulation. Sorry about that. So my presentation outline is under peripheral electrical stimulation. I will briefly talk first about what are the considerations when we are using a PES in a rehab setting. And then I'll talk about neuromuscular electrical stimulation, and then we'll go into functional electrical stimulation. And most of my talk will focus on FES. And within that, again, it will mostly discuss use of FES for upper extremity rehabilitation. We'll talk about the technique of application, the contraindications, precautions. I'll show some clinical trial data. And then lastly, like I said, we'll touch a little bit on use of FES with non-invasive brain stimulation. So first we'll talk about peripheral electrical stimulation. Now, peripheral electrical stimulation is as such not a new technique. It has been around for quite a while now. In fact, its first instance of use was back in 1744, where a German physician found that electrically stimulating hand muscles in a woman who had paralysis resulted in regaining of movement, or the way it says here, lost the paralysis. So really, this thing has been around for quite a while now, although it has been refined significantly from what existed back then. So when we talk about peripheral electrical stimulation, like we know that it is an artificially produced muscle contraction. And there are certain factors that influence this artificially produced muscle contraction. There are more than the ones listed on the screen, but these are probably the important ones. So first we'll talk about impedance, or the resistance that the tissue offers to the flow of current. Then we'll talk about electrode size and positioning, pulse amplitude, pulse duration, frequency, and ramp times. So impedance of the tissue. When we talk about impedance of the tissue, it's really the resistance that the tissue offers through the, to the flow of current. And what we know is that tissues that have higher water content allow easier passage of flow of current. So for example, if you're stimulating a muscle, because the muscle has a larger water content, electrical current will pass more easily through a muscle. And on the same note, because water content in fatty tissue and bone is less, electrical current does not pass that easily through those structures. The nature of layers of the skin plays a role, keratin being the main barrier to the current's passage. Then the next one is electrode size and positioning. So this particular diagram talks to positioning of the electrodes. As you can see in figure A, the electrodes are positioned fairly closely together, whereas in figure B, they are placed a little bit further away. So hypothetically in this figure, what we're assuming is that one thing we know for a fact is that the surface tissue offers more resistance to the flow of current compared to the interstitial tissue. So hypothetically, let's assume that each patch of the surface tissue is offering 10 units of resistance, and each patch of the interstitial tissue is offering 5 units of resistance. So if we place the electrodes too close together, as we can see, the gray colored arrow on the top, if it has to pass through just the surface tissue, then in total it is encountering about 30 units of resistance. Now, if the current had to pass deeper, then it would encounter about 35 units of resistance, and current will try to flow in the least resistance environment. So in this case, because the electrodes are closely placed together and there will be less total resistance when the current passes superficially, the current will remain fairly superficial. Whereas considering the same scenario for B, when the electrodes are placed further apart, less resistance is offered when the current travels deeper, because the current travels a longer distance in the interstitial tissue compared to the surface tissue. So when the electrodes are positioned further apart, then there will be deeper penetration of the current. Having said that, there are other factors that influence the electrode positioning as well. For example, very intuitively, it would be the size of the muscle. So for larger electrodes, obviously, you need to position the electrodes further apart. For smaller muscles, that may or may not be feasible. Another factor might be specificity of the stimulation. So how specific do you want to be in your stimulation? Do you only want to stimulate one muscle, or are you okay with stimulating a group of muscles? So those kind of considerations. Then talking to electrode size. So electrode size will depend on the size of the muscle and specificity, like we just said. So these are just some examples of where electrode size changes based on the type of muscle that you want to stimulate. So for example, in this case, the round electrode on the thenar eminence of the hand is meant to stimulate the thenar eminence, specifically the opponents and the abductor pollicis brevis muscles, to produce an opponent's kind of pinch. And the square electrode is essentially the ground electrode. So we need the electrode smaller. If I had to put a bigger electrode on there, then I would lose the specificity of contraction, of stimulating the muscle. Whereas in this case, the goal is to stimulate the wrist and finger extensors. And we are stimulating the dorsal aspect of the forearm. So because it is a larger muscle and we want a group muscle movement, it is okay to use a larger electrode in this particular case. And then here we are really stimulating the lumbrical muscle. So really thin electrode, again, mostly related to specificity of stimulation. And this is, we'll get into the details of it, but just to quickly mention, this kind of electrode is used when we are stimulating to produce a very specific type of grasping pattern, which is called the lumbrical grasp. Then pulse amplitude and pulse duration. So motor responses can be controlled using pulse amplitude and pulse duration. Now, this may or may not be feasible in commercial stimulators that are out there. Most stimulators only allow for controlling pulse amplitude. But nonetheless, I think there are more and more stimulators that are now being made available where therapists and researchers and clinicians have the ability to manipulate more than one parameters. So talking to this graph, what this is showing is that by using a pulse duration, for example, of 200 microseconds, you can change the contraction from threshold to near maximal by altering the amplitude anywhere from 20 to 40 milliamps. And on the on the other side, if you keep the current intensity constant at 40, then again you can manipulate the type of contraction that you're looking for by changing the pulse duration anywhere between about 40 to 50 to 200 microseconds. Then we talk about pulse frequency. So lower pulse frequencies produce a twitch contraction, and higher frequencies are required to produce a technic contraction. Now, most of the times when electrical stimulation is used for the purposes of retraining a functional movement, we want to produce a contraction that is as close to a physiological contraction as possible. So obviously, we're looking for a technic type of contraction. So we want to use higher frequencies. The one thing that needs to be kept in mind when we are using higher frequencies is that higher frequencies also result in quicker onset of fatigue. So there's a little bit of trade-off. So typically, when we have used peripheral electrical stimulation in the FES form, we have typically used frequencies between 30 and 40 hertz. That's a good balance where there isn't a really quick onset of fatigue, and yet we get an acceptable contraction. So then moving on to neuromuscular electrical stimulation. So NMES is a type of peripheral electrical stimulation, and it is administered with the patient completely passive or performing isolated muscle contractions. And I think that this distinction is very important because sometimes NMES and FES is used interchangeably. It's not technically the same thing. So in NMES, either the patient is completely passive and the electrical stimulation is producing the movement for the patient, or the patient might be performing the movement that is assisted by the stimulation, but it is an isolated muscle contraction with no functional component to it. So typical indications for NMES, and this is a commonly used modality in rehabilitation. It's used for strengthening muscles, reducing spasticity to increase the excitability of the corticospinal neural pathways, and also to augment neuroplasticity. So then moving on to functional electrical stimulation. Functional electrical stimulation means stimulating a nerve or a muscle in such a way that the resulting movement is useful. And this is an oversimplification of the definition. So really what we are trying to do with FES is that we are trying to produce task-oriented movement, which is required in day-to-day life to produce a certain function. And that's really where FES works best, or that's the bottom line when we talk about functional electrical stimulation, the purposeful movement, the task-oriented movement. So FES is not as such a new technique either. It has been around for a while. The first mention of this in literature is in the 1960s, where an FES stimulator was used to assist a patient with foot drop during gait. So essentially the stimulator was used to produce dorsiflexion during gait to assist the patient to walk better. Now, there are two main approaches to functional electrical stimulation. It can either be applied transcutaneously, and this is done typically using self-adhesive gel electrodes. There are many other types that are available as well, but basically these are non-invasive in nature. The other application is invasive electrodes, and this can be in various forms. So we can be using percutaneous wire electrodes, they can be intramuscular electrodes, or they can be cuff electrode, which typically goes around the nerve. Another classification of the FES, and I'm going to stick to only transcutaneous approaches for the purpose of this presentation. So within the transcutaneous approach, there is an approach where we are using FES to retrain a function. So the idea is that you do X number of sessions to train a particular task. Once those number of sessions are completed, the patient will be able to perform that task without the assistance from the FES. So that is one approach. The other approach is where FES is used to produce the function every single time the patient needs that function in day-to-day life. So for example, here, this is an example of an FES device which is used to assist dorsiflexion during gait in a stroke patient. An upper extremity version of this might be where you're stimulating a grasp when the patient wants to, say, eat. So during eating, the patient dons the device, turns the stimulator on, gains the grasp, can eat. Once he's done, takes the device off and puts it away, and then there is no carryover effect. So here again, now we will restrict ourselves to the retraining aspect of FES. So when we are talking about FES for the upper extremity, the stimulation generally uses balanced biphasic current regulated pulses. And these are the commonly used parameters of stimulation. So pulse amplitude can vary anywhere between 80 to 50 milliamps, and this depends upon the size of the muscle, patient tolerance, resistance to the flow of current. So basically patient BMI and fatty tissue over the muscle that you want to stimulate. So those kind of factors, but typical values remain between 8 to 50 milliamps when we are talking about upper extremity stimulation. Pulse width, we typically use between 250 and 300 microseconds. And frequency, like I had mentioned earlier, typically we use between 25 to 40 hertz. I'd say more towards 30 to 40 hertz. That gives us a nice tetanic contraction. So these are just some diagrams to show what kind of electrodes are used for retraining specific movements. So for example, this setup is for retraining forward reaching. So the first electrode is a smaller circular electrode, which is used to stimulate the anterior deltoid. And here we do want specificity. We do not want to stimulate the pectoral muscles. We do want to restrict our stimulation to only the anterior deltoid. Then the second one is for the biceps, and then the third one is the ground electrode. And as you can see that with this particular stimulator, we actually have the advantage of grounding two active electrodes with one ground electrode. Most stimulators do not allow for that. So you would need an individual ground electrode for every active electrode used. And then this is the same FES for reaching. So technically the movement here is to reach forward, grab something, and then retrieve it and put it down or put it on the table, whatever it is that the therapist is trying to train. So posterior deltoid for the retrieving kind of movement. And like you can see here that we are using two separate ground electrodes, one for the posterior deltoid and one for the triceps. Then FES for grasping. So the types of grasps that can be trained with FES vary widely. So we can be as gross as training. This is a lumbrical grasp for grasping books. or it can get as fine as holding a key or even holding a peg with using a 2 or 3 finger pinch. And again, more gross grasping patterns like a spherical grasp, cylindrical grasp. So all of these grasps can be trained using surface functional electrical stimulation. So how does it work? So for example, we are trying to train a palmar grasp. So what would we do? We'd have to stimulate the flexor digitorum superficialis and profundus to produce the hand closing movement. And along with that, we'd stimulate the thenar muscles to get the thumb into the opposition position. And that completes basically the grasping part of the task. And then we would stimulate the extensor digitorum as the release part. So this is the electrode placement for training something like a palmar grasp. So the first one is for the opponent's pollicis. We have the ground electrode for that on the wrist, and then we have 2 active electrodes, one for the flexor digitorum superficialis and profundus, and all of these are grounded using the electrode on the wrist. And then posteriorly, we are stimulating or rather on the dorsal aspect of the forearm, we are stimulating the extensor digitorum, and it has its own dedicated ground electrode. So this is a figure to display the electrode placements for a lumbrical grasp. And I want to draw your attention to a couple things in this figure. Excuse me. So the first electrode is to stimulate the extensor digitorum, and this is actually to stabilize the wrist in extension during the lumbrical grasp. Then the one on the wrist is the ground electrode. And as you can see that the lumbricals have more than 2 digits, we know this. But because the stimulator had this restriction of 4 channels, we were not able to stimulate all of the digits. So we decided to do the alternate one in the hope that because they all are attached to the same tendon, we will be able to get a good lumbrical grasp, and we did. And the figure below shows the positioning for the opponent's pollicis, and again, the ground electrode for the opponent's pollicis. That's for the pinch grasp, so 2-finger pinch, again, lumbrical, opponent's pollicis, and then the ground electrode. And in this case also, I believe both the active electrodes were grounded using the same ground electrode. So how does this protocol work? So basically, the patient attempts to voluntarily execute a goal-oriented task using an appropriate grasp. And this is very important because this really are some of the differentiating points of FES from NMES. So here, we ask the patient to voluntarily attempt to execute the movement irrespective of the level of function available. What FES does is once the therapist detects that the patient is attempting to execute the movement, but obviously is unable to do the required movement, then FES assists the patient to carry out the part of the task or the whole task based on individual patient ability. Successful execution of the task provides sensory feedback that the task was successfully completed. So FES training provides both efferent input and afferent feedback, both of which are essential for CNS network training. So now we'll move on to the technique of application. Here I have a video of how do we go about doing the electrode placement, identifying the amplitudes of current required for a particular training, and then I have a couple tasks to display. Now, unfortunately, I can't get the volume on this video to go, so I'm just going to talk to it while it plays. Here, although I'm training for a full forward reach grasp, I'm only showing you for the sake of time how I'm adjusting the intensities for the hand opening and the hand closing. So this gentleman has suffered a stroke, and he's at least 12 months post-stroke. So he's chronic stroke, and he has very little function in his hand, almost none. So he's unable to open his hand on his own. And here what we can see is that when we are setting up the amplitude, we want the patient to not do anything because we want to identify the amount of current that is required to elicit the opening. So really, we are asking the patient to not do anything while we are setting up. Now here you will see that I'm setting up the intensities for the hand closing. And because this gentleman has quite a bit of spasticity in his finger flexors, we keep the intensity only to a level which acts as a cue for him to initiate the movement. And then, of course, throughout this process of setting amplitude, we are constantly asking for feedback from the patient because we want to make sure that the current is comfortable. So now I'm setting up the amplitude for the proximal muscles. Because we are training forward reaching, we typically tend to stimulate the scapular stabilizers as well. So the muscles that we're stimulating right now are the upper trapezius, the lower trapezius, the serratus anterior, the anterior deltoid, the triceps, the biceps, and the finger extensors and hand closing. So this particular stimulator does have multiple channels, so it allows us to stimulate multiple muscle groups at the same time. So right now, I'm sorry that you're not able to see it that distinctly, but I'm trying to set the intensities for the upper trapezius, the serratus anterior, and the lower trapezius. Now, for certain muscle groups like the upper trapezius or the finger extensors or for hand closing, the movement is very obvious. So we have this feedback that is the current good enough for the task that we are training. But for certain other muscle groups, like for example, the serratus anterior or the lower trapezius muscle, there might not be an obvious movement. So palpation plays a huge role. So we typically palpate for the muscle that we're setting up. And we also constantly ask for patient feedback in this case, because we really want to know if the current is strong enough and if the patient can feel the displacement of the bone, so to say, or the contraction of the muscle, one or the other. So that's how we typically do the intensity setup for muscles that we are only able to palpate and that we are not able to see an obvious movement for. So here I'm setting up the serratus anterior. The screenshot in there showed the electrode placement for the serratus anterior muscle. So now once the setup is complete, you will see that this is a training for forward reaching with hand opening and hand closing. So the instructions that I'm giving to the patient is that you want to try and attempt the movement on your own. So as soon as I start, I'm going to give the instruction to the patient, open your hand, open your hand, open your hand. And once I feel that the patient is attempting to do that, I will assist using the FES. And in this case, because I'm operating the FES with a push button that is operated by my feet, you can't really see why or how the FES is coming on. But that's really how the FES is working in this scenario. So that was opening of the hand, closing of the hand. Now you will see that I'm going to ask him to try and raise his arm forward in a forward reaching position. So again, he is attempting the movement. And if you did notice, there was one point where you could tell that the FES has clicked in. So we want him to try and do the best as he can and then use the FES to assist the movement. Here again, so forward reaching, hand opening. And I'm just asking him to try and hold his arm in forward flexion. Again, positioning is important. You want to make sure that the patient is not using trick movements, which is quite common in stroke particularly. And the patient patient is constantly providing feedback regarding what he's feeling, how he wants the movement to look like on his affected upper extremity. So that is actually really very helpful when we are doing therapy with these patients. And in a typical session, I would say that we're able to practice one particular movement for about 10 to 15 repetitions before which fatigue sets in, after which fatigue sets in. So then what we do is we cycle through different types of movements, stimulating different muscles so that we are circumventing the fatigue issue. So again, trying to get him to hold and forward flexion, and like you can see that he's able to momentarily do that. Again, this is with the assistance of FES. This is not just his voluntary contraction. Again, hand opening. It's a little bit of assistance, stretching it out because he does have severe spasticity in his finger flexors. Again, stabilizing him. This is a different task that we are training now. So this is a hand-to-mouth task. Here, the instruction for him is to lift the tennis ball off the table, pretend as though it's an apple, bring it to his mouth, and then put it back down. So very functional in nature. I'm going to help him to put his hand around the ball. Then the FES kind of cues when to bring the finger flexors on, so when to start closing his hand. He's going to try and bring it up to his mouth. Again, he is requiring help of the FES to raise his arm up, and then he'll bring it down. And I'm going to ask him to try and let go, let go, let go, and then superimpose that effort with the FES to actually help him release the object. This is another example. We use a lot of day-to-day objects when we are doing training with FES. Sometimes we ask patients to bring their own objects in, and it's very goal-oriented. Patients do tell us what are the kind of activities that they'd like to get trained on. So we try and do our best to see if we can actually help them regain function around their goal setting. And there. Okay, so moving on, contraindications for use of FES. So cardiac pacemaker, skin lesions, or a rash at a potential electrode site, or a metal implant at the site of stimulation. These are all considered contraindications for use of FES. Specific to medical condition, cardiovascular conditions such as uncontrolled hypertension and stroke, these are not necessarily contraindications. These fall more into the category of precautions. So we can consult with the physician or the physiatrist and see whether or not it is safe to use FES. But nonetheless, these factors do need to be kept in mind. Then when we're talking about spinal cord injury patients, patients with autonomic dysreflexia requiring medication might require a little bit of closer supervision. And then in patients with denervated muscles, the application of electrical stimulation is slightly different. So now I'm going to show you some clinical trial data. This is a study that was done in individuals with subacute SCI. So all of the individuals recruited to this study were less than 6 months following a spinal cord injury. All of them had sustained a cervical spine injury, and all of them received 40 hours of FES therapy plus another 40 hours of conventional occupational therapy. And this is because these subacute SCI patients are inpatients at a rehab hospital, and they're entitled to 40 hours of therapy. So ethically, we cannot deny that because that is considered best practice. So they get that, and then as their participation in the research, they get an additional 40 hours of FES or 40 hours of another 40 hours of conventional occupational therapy based on their group allocation. So these are their scores on functional independence measure self-care subscore. So for those who might not be familiar with the FIM self-care subscore, essentially this asks, it's a subjective scale, sometimes administered objectively, although most of the times it is administered subjectively. We ask the patient their ability to perform various functions like eating, grooming, toileting, dressing, and then we score them based on the amount of assistance they required with these kind of activities of daily living. And 42 is the maximum score that they can get on this particular self-care subscore. and higher scores indicate more independence in the performance of a function. So here on the y-axis, we have the FIM scores, and on the x-axis, we have individual patient scores at baseline in the gray bars, and then the blue bars indicate their scores post-intervention. So as you can see that both the control group and the FES group have realized some improvements following therapy. However, there is a median change of 25.5 points on the FIM in the FES group compared to 9.5 in the control group. So this is the same sample, but this on a different outcome measure. This is called the spinal cord independence measure self-care subscore. And this is actually not too different from the FIM. This also asks patients their ability to perform various activities of day-to-day living and how much assistance they need with that. So ask similar questions like eating, grooming, toileting, dressing, and how much help you need with it. But this is more specific to the spinal cord population. And on this one as well, higher scores indicate better performance. 20 is the highest that the patients can score on the SCIM self-care subcomponent. So again, the y-axis is the score on the SCIM, and then the x-axis is individual patient scores at baseline in the gray bars, and then the blue bars indicate the improvements that they have realized upon completion of therapy. So again, as we can see, both groups improved. However, the median change for the FES group was 12 points, and that for the control group was 3 points. This is a sample of chronic SCI participants. So these patients are more than a year post-injury, and some are actually can be 8 to 10 years post-injury, so really chronic in nature. And this is their performance on FIM self-care subscore. Excuse me. The y-axis is again the FIM self-care subscore. The x-axis is individual participant performance. The light orange bar indicates their performance at baseline. The middle bar is their performance upon completion of 39 sessions of therapy. And then we typically do a follow-up at 6 months from baseline to see whether or not they have retained or improved further on these measures. So that's what is displayed here. And as we can see again, in the control group, a couple participants showed some improvement, whereas in the FES group, we had better improvement. So in this case, the mean gains upon post-therapy for the control group was 0, and at 6 months was 1.4, whereas that for the FES group at post-therapy was 4.6, and at 6 month time point was 8.3. So definitely the FES group had better improvement in function as compared to the control group. But I also want to draw your attention to the fact that as patients get chronic, the improvements are not as drastic as we see in the subacute population. So this is again, same sample of chronic SCI patients on the SCIM, and in this case, also on the SCIM as well, there were better improvements in the FES group as compared to the control group. So these are just very short clips of before and after videos. So this particular clip is for a chronic stroke patient. He is 8 years post-stroke. He had received a lot of therapy after stroke, subacutely after stroke, but unfortunately he didn't experience a whole lot of improvement in function. When he came to us, he had no movement in his arm at all. So he just had a limb hanging by his side. So he was a case study actually. So he just received FES, and this is him at 15 sessions. So this is him at various time points during therapy. I'm going to play the video. So here I'm asking him to forward flex or lift his arm straight up. I'm standing in front of the participant facing him, and I'm showing or demonstrating the movement that I want him to do. Now this is him at 40 sessions. So still the same movement, but as you can see that there is better improvement at 40. And this is him upon completion of 80 sessions. So this is a very rewarding experience where a patient comes in with literally zero function in the R and is able to do more than baseline and actually quite a bit in terms of activities of daily living. So really a very humbling moment for us. And this is a before and after video of a chronic SCI patient. So this patient is also more than 1 year post-SCI. And when he came in, he really wanted to be able to drink water by himself independently, really a very basic task. So he came to us saying that he would want to be able to do this so that his wife does not have to help him every time that he needs a drink of water. So let us see how he does before and after. So this is session 6, and this is without the assistance of FES. So this is just him trying to bring the bottle to his mouth and drink out of the bottle. And this is after 33 sessions of FES. Okay. So now I'll just talk about a couple advances in FES. So like I mentioned earlier, that compared to the 1744 stimulator, we've come a long ways. Some of the newer stimulators, for example, the MindMove has the ability of stimulating up to 8 muscles. It is still a non-invasive therapy. It still combines patient participation with therapist expertise, and FES literally just assists in therapy. And it is used to restore voluntary hand and arm function in patients suffering from upper limb paralysis. So this is what the stimulator looks like. This one has inbuilt programs, so you can really select what you want to train based on individual presentation of the patient, proximal function, distal function, combination of proximal distal function, and then the stimulator will take you through the steps of setup. Once you have set up the patient, then you can operate the stimulator using these round push buttons. These push buttons can be operated with the hand or leg, so mostly we put them under our feet because then we have the hands free to kind of guide the movement. Another one is the Excite 2. This has the capabilities of stimulating up to 12 muscles. So really we've come a long ways from those primitive stimulators, and these stimulators really ensure that we are able to train the most complex form of activities. So how does FES work? FES works through multiple mechanisms. The peripheral mechanisms include increased oxidative capacity of the muscle, increased myocapillarization, and transformation of muscle fiber types. Spinal mechanisms include strengthening of the synaptic connections in the ventral horn, leading to altered excitability of the spinal motor neurons. And the central mechanisms include increased corticospinal excitability associated with unmasking of spinal synaptic connections, as well as LTP-like changes. So what we know is that electrical stimulation, when applied with voluntary activity, or at the minimum an intention to move, is required to induce change in corticomotor excitability in healthy participants as well as in patients. And ES-induced corticospinal excitability depends on stimulus amplitude and the nature of muscle contraction. So now just a little bit about FES and in combination with non-invasive brain stimulation. The role of NIBS in neurorehabilitation is really to prime the motor learning acquisition, typically with excitation of the affected sensory motor cortex and or inhibition of the competitive brain areas. So rehab and non-invasive in combination with NIBS is a newer field. However, I think in the past couple decades, considerable amount of studies have been happening in this space, and various groups have tried to combine various types of rehabilitation maneuvers with NIBS in the hope of producing better outcomes for our patient population. So this is just a a table from a systematic review that was recently completed, which looked at studies that have tested rehab in combination with NIBS over the last 10 years. And as you can see, when you look into the column of combined therapy, really patients have, or rather, sorry, researchers have combined NIBS with different types of therapy. So PT, task-oriented therapy, virtual reality, mirror imagery, NMES, robotic-assisted training. So orthotic training. So really a lot of studies out there that have tried to combine these in the hope that we can produce better outcomes for our patients. In fact, when I tried to look it up, this is an interesting slide for me, because when we put in the search words of rehabilitation therapy with NIBS, as you can see that most of the work in this space has been occurring between the years 2003 and 2022. So really a lot of interest in this space over the last couple decades. Now, most of the systematic reviews that have looked at a combination of rehab in NIBS have concluded that, however, in the process of analysis, it was difficult to determine the most appropriate brain stimulation method because each study had different methods. Additionally, it was difficult to prove the effectiveness of a single treatment method because studies compared brain stimulation fused with different types of rehabilitation treatments. So where does FES fit in this scenario of rehab plus NIBS? So personally, I feel that a task-oriented approach is very important to regaining function. And that's where FES has an edge over NMES techniques. Now, in patient, and also what systematic reviews have shown is that NIBS techniques, when used in combination with specifically task-oriented approach or occupational therapy, they tend to produce better results. So this is an affirmation of the fact that task-oriented approach is really very crucial. And the thing that FES allows is, even for the patients that are severely paralyzed or have severe impairments, FES allows for them to perform purposeful movements with minimal assistance on their part, which is really a big deal because there are not many rehabilitation therapies out there where the patient can be involved in functional movements when they have high levels of impairment. They're typically just reduced to passive movements. So in that sense, I think that FES really offers a venue for exploring if there is room for further improvement in patient outcomes by this combination therapy. Thank you so much for your time. And I'm going to stop sharing my screen.
Thank you very much, Naaz. Great presentation, as I knew it would be. Yeah, thank you very much for guiding us through that. It was great to, for me personally, to get more of an insight into functional electrical stimulation. I've not an area I have been exposed to it very much in the past. As you know, we're very focused on non-invasive brain stimulation, but it's also nice to see the potential of the two techniques working together as well, and see the interest in doing that in recent studies, which is great to see. I was going to sneak in a little question of my own, but then you did address it in how you looked at the stimulators available for this technique and how they can be programmed and how they've advanced a lot since the more primitive stimulators were used in the early days. Just a reminder then to the audience, you can ask your questions in the chat or raise your hand, in fact. So we do have a question to go to already. So Dr. Rupam, I'll try and allow you to talk. If not, as a backup, I can read out your question for you. But you should have a message popping up now to say that you can enable your audio to ask your question directly. I'll give you a few seconds to see if that works or not. Sometimes it does, sometimes it doesn't. So yeah, as I said, I can jump in to ask if needed. Okay, I think we should be able to hear you now. If you'd like to go ahead and ask your question, Dr. Rupam. No. Great. So I'll go ahead and ask it for you. So can we use FES for LMN type lesion? If no, then why? Or no role for FES in LM like GBS? I hope that means more to you than it does to me.
Yes, yes. So that's a very interesting question. And like I touched based on it a little bit, that when the muscles are denervated, it is a little bit more trickier. So typically in denervated muscles, and I have more experience in spinal cord injury and stroke than GBS, but I think that the fundamental concept might not change. So basically, when we are stimulating a denervated muscle, we know that the central, the connection is not there. So the retraining aspect is not that crucial unless, of course, say, for example, it's a neuropraxia kind of an injury where we are expecting that the patient will regain function eventually down the road. So otherwise, FES is used more as an orthotic in those patients that have denervated muscles.
Thank you. As we wait for anybody else that might want to ask a question, I would like to just maybe throw in one of my own. So going back to the videos that you showed of the examples of some of the training and the tasks, for example, the reaching versus the grasping in the first video, was it necessary then with that particular device, do you have to reprogram it for those channels, or is that something you set up all at the beginning and then you can switch between programs in the software to do the different, to activate the different muscles for each of those two exercises?
That's an excellent question. So if we are going to be using the same muscle groups, then the electrode placement and all remains the same. But we do have to select a different program based on what we want to train. So if I'm doing forward reaching, then I need to select the forward reaching program. And say, for example, then if I want to move to, I don't know, sideways reaching. So then I would have to go and select the sideways reaching program, because then a different set of muscles need to be stimulated to produce that movement. But having said that, so for forward reaching, I'm stimulating the triceps. Potentially for sideward reaching, also I would be stimulating the triceps. So the electrode placement remains the same. So you don't need to rip all the electrodes off based on what kind of change you're doing in the protocol. Those can still stay. But yes, irrespective, you still need to come out of the that particular protocol, click on another protocol, go through the amplitude setting steps, and then you're good to go.
And does it go down to the level of different timing for each muscle in that one program, or do they all activate together?
That's an excellent question. So no. Most of the stimulators have this on-off parameters, right? You can set it so the stimulation comes on for 2 seconds, ramps down, stays off for 2 seconds. With this one, essentially, once the setup is in place, you have the total control. So you push the push button, the current comes on, stays on until you push it again and ramp it down. So really, you are in charge. The therapist is in charge, right? So because sometimes patients require a little longer to get their hand around objects. Sometimes you want to train an isometric contraction, so you want the patient to stay in that contracted state for a bit. So really, like with this one, there is no on-off time. You can let the stimulation last for as long as you think you need it for the task training.
And I can see then the benefit of the foot pedal to enable you to still assist with your hands and do that. So we've had a load of questions just come in as well. So rather than go through and unmute everybody and lose any time like that, I'll just go ahead and ask them directly if that's okay. Can you be able to learn or relearn complex action like playing a violin? The example from Ricardo.
Personally, I've never trained anyone for violin, so let me say that up front. Yeah. When patients come to us, these are patients who have relatively severe impairments. And for our clinical trials, we have targeted patients with severe impairments because most research studies do not recruit such patients. So when they come to us, their requirements are very basic in nature. I want to be able to eat independently. I want to be able to dress independently. I think the most complex that I have gone is there was a complete SCI patient who wanted to be trained to be able to insert a key in his van so that he could drive his adapted van to and from therapy without help. So then we focused on training him just to get that key in so he didn't need any other help. So I think that is, and I have trained people for writing, because their signature, they can sign documents, and that becomes a limitation from legal perspective, especially when they have suffered an MVA or something and they have to sign tons of documents. So we have done training for writing. I don't see a reason why we couldn't train for violin when we can get as precise as a 2 and 3 finger pinch. I don't see why, because with lumbricals, you can actually control the fingers too. So I don't see a reason why, but unfortunately, personally, I've never done that. So
yeah, that's good to hear. The range. I imagine then the number of sessions needed goes up significantly for those more fine motor control.
I would think so. Yes, just given the precision of the activity.
Yeah. So another one here then. So there are some researchers who say that the combined use of FES and NIBS could reduce the effect of NIBS. How to measure these effects, if you have any thoughts?
That's a good one. So I am actually conducting a study of my own to actually see this, right? And I'm still midway, so I don't want to talk too much to it. Who knows, everything might change by the time I finish. But you have a good point. So when we are talking about NIBS and FES, we know that both, well, NIBS, if you're using certain types of techniques, then they're facilitatory in nature. And FES for sure is facilitatory in nature, right? So immediately combining those two might sound counterintuitive, because there's so much excitation that you might cause an inhibition at the end, right? But what we are looking for really is what this does in the long run, right? It's not a one-day thing, right? So I think that what we need to eventually look at is to see that if we do this, you do an NIBS, which might be excitatory in nature. Within that time frame, you do the FES, and then you measure the patient after, I don't know, 20 sessions, 30 sessions, and see if there is an additive effect there. Because that's what we are really interested in, the additive effect, right? So that we can reduce the number of sessions, we can provide better outcomes in a shorter duration.
Yeah, I understand. And so a related question then from Oranich. So from your clinical trials, what's the suggested intensity of the training sessions for stroke patients to regain their function? So a number of sessions per week, for example, rather than the total number of sessions.
So in our experience, I think 3 is the minimum that you need in a week. So we recommend generally 3 sessions per week. We've gone up to 5 sessions per week as well. The sessions are typically 45 minutes in length, including the donning and doffing time. So the stim time can vary between 30 to 35 minutes based on individual participant performance, impairment, fatigue levels, so on and so forth. So yeah, we do 3 to 5 times a week. Total number of sessions, I'd say that a minimum of 20 sessions are needed to see clinically meaningful difference.
Yeah.
But again, this is very individualized. The one clip that I showed you before and after for the chronic stroke guy, that was 80 sessions, after which he actually was able to take his hat off, and which was amazing for us. Like this guy had his arm hanging by his side when he came, like a dead arm. So yeah, so it's individualized, but 20, I would say, is the minimum.
Yeah. Makes me think then as well of like sort of the different healthcare systems around the world, and in particular here in the UK, where we are, you know, as much as I'm a very big fan of the NHS, I think I'm not sure if that amount of time can be given for a patient. You know, I'm not involved in that particular area of rehabilitation, but in Canada is the you know, is that kind of amount of treatment typical or available to a patient, or is it kind of, does it need to be condensed, or yeah, what's your experience there?
So again, I have mostly worked in spinal cord injury and strokes. I'll talk to those. And these patients, when they are admitted to a rehab setting, they are generally there until they can be safely discharged to a destination of their choice.
Yeah.
Having said that, there are still discharge pressures, so they can't stay indefinitely, right? So from what I remember last, I think they were trying to reduce the length of stay to about 30 days. So, but the patients are in there solely for rehab purposes. So within their 8-hour day, they have all the time for you.
Yeah.